Hi guys, how are you? My name is Sofia Correa and today I'm going to talk to you about Roth spots in infective endocarditis. First, we're going to define what is a Roth spot. A Roth spot is a retinal hemorrhage with white or pale centers. It is usually caused by immune complex mediated vasculitis, often resulting from bacterial endocarditis. Roth spots may be observed in leukemia, diabetes, subacute bacterial endocarditis, pernicious anemia, and in other diseases. The second definition that we have is infective endocarditis. This is an infection of the endocardial surface of the heart, which may include one or more heart valves, the mural endocardium, or a septal defect.
It's 12:45.
Its intracardiac effects include severe valvular insufficiency, which may lead to intractable congestive heart failure. So here's a video about infective endocarditis.
Infective endocarditis. Well, infective endocarditis is a microbial infection of the heart endocardium. The heart consists of 3 layers of tissue. The outermost layer is the epicardium, then the myocardium, and finally the innermost layer is the endocardium. The endocardium tissue covers all structures within the heart, including the valves and the chordae tendineae. Just as a refresher, the valves are like a parachute that regulate the movement of blood from chamber to chamber, while the chordae tendineae are the cords that hold the parachute or valves open. Now that we know what infective endocarditis is, we need to understand what are the risk factors for infective endocarditis. Risk factors for infective endocarditis include poor dental hygiene, intravenous drug abuse, hemodialysis, long-term indwelling catheters, diabetes mellitus, and prosthetic valves. If a patient has these risk factors and is in the appropriate clinical setting, you should consider infective endocarditis. Endocarditis can be caused by many different organisms, and we will focus on the most common causes of infective endocarditis. Staphylococcus aureus is the most common cause of infective endocarditis. This is the reason why, if you have a gram-positive bacteremia with cultures that are not clearing or taking a while to clear, it's important to rule out infective endocarditis, as this would affect the patient's duration of IV antibiotics. Coagulase-negative staphylococcus can also cause infective endocarditis, especially within the first few months after prosthetic valve placement. Specifically, Staph lugdunensis has been shown to cause significant valvular dysfunction, frequently requiring valve replacement surgery. Streptococcus can also cause infective endocarditis. Specifically, Strep mutans and sanguis has been shown to play a role in endocarditis. In addition, Strep bovis can also cause infective endocarditis and is usually seen in the elderly. But remember, it is also associated with colonic lesions, so these patients need a colonoscopy in addition to treatment of their infective endocarditis. Another group of organisms is called the Haysick group. The Haysick group of organisms consists of Haemophilus, Actinobacillus, Cardiobacterium hominis, Eikenella, and Kingella. Other organisms that can cause infective endocarditis include Enterococcus, Coxiella burnetii, and fungi. Remember, infective endocarditis carries with it a significant risk for morbidity and mortality, especially if not properly recognized and treated. There are a few clinical signs and symptoms that you need to be aware of. So these signs and symptoms.
Continuing, now we're going to go to applications in medicine. What are the symptoms that we observe in infective endocarditis? First, we have petechia, which is common but non-specific. We have also subungual or splinter hemorrhages, which are dark red linear lesions in the nail beds. Osler nodes, which are tender subcutaneous nodules usually found on the distal pads of the digits, and Janeway lesions, non-tender maculae on the palms. So here
endocarditis is inflammation of the inside lining of the heart chambers and heart valves, endocardium. Endocarditis can involve the heart muscle, heart valves, or lining of the heart. Most people who develop endocarditis have some abnormality of the heart valve. Endocarditis symptoms: abnormal urine color, chills common, excessive sweating, common. Fatigue, fever, common. Joint pain, muscle aches and pains. Night sweats, nail abnormalities. Paleness, red, painless skin spots on the palms and soles. Red, painful nodes in the pads of the fingers and toes. Swelling of feet, legs, abdomen. Weakness, weight loss. Endocarditis treatment.
So those are the symptoms. Now the diagnosis. The Duke diagnostic criteria developed by Durek and colleagues are generally used to make a definitive diagnosis of infectious endocarditis. The criteria combine the clinical, microbiologic, pathologic, and echocardiographic characteristics of a specific case. So, what is the Duke diagnosis criteria? Here's a video that shows you the different types of criteria, which divide into major and minor. So for the major ones, we have positive blood culture, positive blood cultures which are persistently positive on over 12 hours, positive echocardiogram, and new valvular regurgitation. Now they're showing the minor criteria. So for the minor criteria, we have fever that's over 38 degrees, cardiac lesions or IV abuse, clinical signs, and ECNO not meeting major criteria, and also the culture not meeting the major criteria. So those are the major and minor criteria. So if we continue, we're gonna talk about the treatment, which rely on antibiotics, which remain the mainstay of the treatment of, i.e., 3 to 5 sets of blood culture should be obtained within 60 to 9 minutes, followed by the infusion of appropriate antibiotic regimen. Pros and cons. This disease is not very difficult to diagnose, as I already showed you the criteria that you have to have in mind in order to diagnose it easily. Also, it is easily treated in early detection. However, it could lead to other fatal diseases, and if it's diagnosed late, it could also be fatal. What about the related disease? We have a heart murmur. A heart murmur is an extra or unusual sound heard during the heartbeat. Sound heard. Murmurs range from very faint to very loud. Sometimes they sound like a whooshing or a swishing noise. So I found this video very interactive, very interesting for medical students like me especially. And then I'm going to show you a video that's more appropriate for patients.
Heard a murmur?
Don't panic.
In this video, we'll be taking you through the basics of what to do next. Unfortunately, we don't have any fancy sample murmurs for you to listen to. For those, we'd strongly advise you go stick your stethoscope on some real-life patients. On to the diagnosis. The first step in diagnosing the murmur is to correctly identify where it occurs during the cardiac cycle. Feel the radial pulse while you listen. Systole is the period during the upstroke of the pulse, coinciding with the first heart sound. Murmurs can therefore be classified as systolic or diastolic. Systolic murmurs can be further differentiated into ejection systolic murmurs and pansystolic murmurs. That's throughout systole. Diastolic murmurs can be further differentiated into early diastolic and mid-diastolic. Now it's okay for this to seem confusing at first. Much like the work of Pink Floyd, murmurs are complex, and true understanding can only come from sustained listening over time. Let's take a closer look at 4 common murmurs, starting with
Mitral stenosis.
mitral stenosis is a mid-diastolic murmur. It is best heard by listening over the apex using the bell of the stethoscope. It's easier to hear if you ask the patient to hold their breath and roll to the left.
Mitral regurgitation.
Mitral regurgitation is a pansystolic murmur. It's also typically heard over the apex, this time using the diaphragm. MR often radiates up into the axilla.
Aortic stenosis.
Aortic stenosis is the classic ejection systolic murmur. It's most often heard over the aortic area and commonly radiates to the carotid arteries.
Aortic regurgitation.
Aortic regurgitation is an early diastolic murmur, most often heard in the tricuspid region. It's best heard by leaning the patient forward, asking them to take a deep breath in and out, and hold. Murmurs are graded on a scale of 1 to 6. In general, the presence of a palpable thrill indicates a higher grading, while murmurs that are trickier to hear don't score quite so many points.
So, I think that was very useful for us. Now for the patients, this is a more appropriate video.
You may have been told that you have a heart murmur. But what exactly is a heart murmur? Heart murmur is just a sound that your doctor hears when he uses a stethoscope to listen to your heart. Now normally we don't necessarily hear blood moving from one chamber of your heart to the next, but if we do, it's called a heart murmur. Many heart murmurs are completely benign. They're called physiologic. It just means that because of your body size or where your heart is, you can hear blood moving in your chambers. But it may be a sign of an underlying valvular heart problem. There's 2 major valve problems that cause murmur. One is called stenosis, where the valve doesn't open correctly, and the other is called regurgitation, where the valve opens okay, but blood leaks back through the valve when it closes, causing a murmur. Now, the best way to check out a heart murmur is with a test called an echocardiogram, or a heart ultrasound. That test looks at the heart, looks at the valves, looks at the pump, and can tell you exactly what's going on with your valves. That's the best way to check out your heart murmur.
So yeah, that was it for the video. Thank you.